right. Welcome to Planetary Health First, Mars Next. And if you would have heard what we were talking about in the green room, well, sorry, you just couldn't hear it. Anyway, we're live. We're doing great. We have an amazing, awesome guest, Gregg Kemmer, and he is no stranger to healthcare. I think we've all heard of Humana, we've heard of CVS, and hopefully we've heard of ATRIO Health, where he's at as the CEO and president of this health plan, this Medicare Advantage healthcare plan. And I have my good friend Charles Gellman. He is no stranger to healthcare as well. He's a med tech CEO, HIDO Health, and we're here today, and we're going to talk a little bit about healthcare, just to say the least. Gregg, do you want to introduce yourself real quick to our audience?
Yeah, happy to. Thank you for the opportunity, sincerely. Gregg Kemmer. I am the CEO and president of ATRIO Health Plans. We are based in Oregon. We also do business in Reno, Nevada. 100% of my experience in healthcare has been Medicare Advantage, both through Humana and then Aetna/CVS. I find myself lucky to be here because we could all do something different for a living than we're doing right now. I take a lot of pride saying that I design health plans for seniors and those who are eligible for Medicare who may not be seniors, so that they can see the best doctors for the best price at the best facilities. And that's kind of my North Star. So thank you for having me.
Thank you for joining us. So where do we start? We want to make sure we don't go off crazy conspiracy rabbit holes. This is strictly healthcare. And I think what I would say, what you were sharing earlier, really about the importance of really doing what you're doing for the members, really taking that, and how you at ATRIO Health really make sure. What I heard when you were sharing is honor. It's really honoring our older adults and those other population, the younger with disability that are eligible for Medicare. So I'd love for you to have an opportunity just to kind of share that vision and how you're operating with that.
Yeah, so we work to serve the most deserving population in America, in my opinion, which is the seniors, as well as those who are eligible for Medicare, who may not be part of the senior population. I think it's important to recognize that in our business, we can't start with an idea and then push it forward. We have to start at the end with the consumer in mind and then bring those ideas backward. Okay, so I can assume sitting behind a laptop that a cost share of X will be good for the member. That may be wrong. I need to go to the member to find out if that is wrong or right. We are a B2C business. And so we rely upon the input from the communities and the brokers and independent agents who serve those communities and our members to work our way backwards from their input to inform our plan designs, inform our network composition, and inform just generally how we do what we do. My industry, in my opinion, is very similar to a restaurant. The chef will never come tell the customer what they want to eat for dinner. They can make recommendations. The waiter or waitress is in the same boat. We have to go to the source of what is wanted and work our way backwards, that source being the member, the beneficiary for Medicare coverage.
Yeah, I think it's pretty interesting what you're discussing, Gregg. Really patient-centric and patient-focused. And I think a lot of other health plans that we've seen, the large commercial health plans have really lost that sense of touch with people and really understanding your customers. And that's something that's unique and different, because when you actually understand who you're serving, that's when your product offering can be catered around those individual populations, the needs, the habits, and really touching the community. So my question's really centered around, what makes your particular health plan unique and different versus some of those other health plans when enrollment hits, October 15th to December 7th. Why should people choose your particular health plan versus some of the other ones that are accessible in the marketplace?
Yeah, it's a really good question, Charles. To me, our industry works on the same rule book. We all use the same marketing guidelines. We all use the same rate book, actuarially speaking, to determine what we can do with benefits and reimbursements. So then the question to me becomes, how do you stand out? And one of those ways that we stand out at ATRIO is by offering at arm's reach service to our members. I can tell you with my 2 prior experiences at Aetna and Humana, which by the way were outstanding, wouldn't trade them for anything. There was a lack of personalization associated with what we did because of the size that we were. And so it's a really cool thing to be at ATRIO where we can, like in our headquarters in Salem, Oregon, I've quite literally shaken hands and had conversations and canceled calls to talk with a member. And that member walks in because they have a question about a claim that they received, or they have a question about a doctor who retired and what do I do? And how cool of a feeling to be able to help them one-on-one instead of telling them to go call an 800 number. I mean, you want to talk about personalization and rolling out the red carpet for this population? That is something I frankly obsess over.
Yeah, I love how you're talking about so you feel like with the size, you have this sweet spot that really creates the ability to be agile and also to really better understand your customer. But you also there's leadership that's involved too. I mean, so you have to be designed in a way to do that. So would you like to share a little bit about like your principles, your whatever you would want to call it, your DNA of your company, or I think that would help too.
Yeah, good point. So we have strategic pillars at ATRIO, and there are 8 of them. I won't share all of them. None of them are secret sauce. I would characterize them as common sense. But I'll share a couple of them with you. Number 1 is the member is always first. Okay. You can talk about stars, quality, total cost of care, management, risk adjustment, legal compliance. You can talk about all of these parts of any health plan, irrespective of the line of business that they're in. None of it matters unless the enrollment is made. None of it matters unless the enrollment is made. So then we like to focus on making the enrollment happen. And then it's our job to take care of all the other things behind the scenes to make sure we deliver on the promise that member signed up for. Okay. That's the first pillar. The second pillar is that good news and bad news has to travel at the same speed. It's human nature to put a spotlight on the good news and to hide the bad news. I ask all employees and brokers and members to be just as vocal about anything we need to fix as they are about anything that's going well. And what happens there is you get this quick reaction in terms of what's not working well, which becomes actionable. It becomes actionable data. It becomes something you can act upon to help the member. So I encourage, culturally speaking, bad news has to travel at the same speed as good news.
So what I feel like we've seen some really interesting things recently with Walmart, CVS, with the landscape and also the pressure with CMS, all the pressure you're under, just the landscape in general. Could you share a little more what's going on right now? Just, I know you can't comment, but so much, but just your take, just kind of, if you could, just love to hear it from you.
Yeah, my take, and this is all just my take. So there are nearly 33 million people enrolled in a Medicare Advantage plan. These people vote. And if you're a congressperson, my hope would be that you pay attention to all these seniors who vote. And even if they're not seniors, people who are eligible for Medicare, they vote. Okay, that's point 1. Point 2 is, in my opinion, CMS is making it more challenging for us to do what we do, but they should make it more challenging. They should. This is a population that has been taken advantage of time and time again by people who have bad intentions. Okay. Mm-hmm. I applaud CMS for standing up as an advocate for these folks so that we are held accountable to do what we need to do and that we use their federal dollars for the right reasons. Obviously, on other companies, I can't comment about what they're doing or not doing. But I can tell you at ATRIO, we use the federal dollars as best as possible. And when I say best, I mean most efficient and compliant. We are a compliance first health plan. That's unbendable. There's a period at the end of that sentence. Okay. Beyond that, we try our best to get creative for the benefit of the member to find all the other benefits that are creative in nature, such as SDOH benefits that we can offer them to improve their quality of life. At the end of the day, we get paid to improve their quality of life. And so that's how I think about it. Yeah.
Could you share a little more like how CMS is making it more difficult, like a little more granular? Like, is it the cost reimbursement, or is it specifically with like, you know, not necessarily line by line, but just sort of the overview, sort of some context to that?
Yeah, I'm happy to, but I want to clarify one point. It's not that they're making it more difficult, but I think my opinion, which could be wrong, is that CMS is making sure that those who are truly committed to doing what we say we do are actually committed to doing what we say we do. And ATRIO will live up to that standard. I think that's a standard that should be in place. More specifically, you know, funding was fairly benign this year over year, in terms of funding increases. To be fair, a couple of years ago, it was the highest it's ever been in my career. So if on a 2-year basis, if you average that out, it's kind of status quo. But, you know, star ratings are one area that I can point to where CMS is challenging us in our industry in a unique way. The cut points can move quickly, and it's hard to adapt to those things sometimes. But from what I've seen, objectively, CMS has the member's best interest in mind when it comes to those cut points, whether it's medication adherence or any other category. So our role is to play by the rules that CMS sets for us. We will adapt accordingly because I will not move away from that North Star of taking care of the member.
Yeah. I was going to say, I think that's an interesting insight when you start thinking about, you know, taking care of the member and the regulations. They're kind of always on a moving target, and it's very challenging for health plans to plan out where you don't know necessarily where that target is going. And CMS star ratings, you know, changes have been made where medication adherence is triple weighted now. So now trying to figure out what particular solutions are best fit for that, but also as cost mitigation and utilization increases over time for hospitalizations and ER visits, how do you take care of patients that might have, you know, mental issues or challenges or behavioral health issues at a fraction of the cost, or able to touch them before that high utilization occurs? Are there specific solutions or strategies at a high level that you can think of that maybe other health plans or your health plan are implementing to try to service these potential high cost, high risk patient populations?
Yeah, in my opinion, really good observation, Charles. In my opinion, it goes back to service. Because for the most part, the same cost shares or copays that I offer are going to be very similar to what other competitors offer. So then again, how do you distinguish yourself? To me, it's service. We have a personalized service at ATRIO whereby we encourage the members to walk into our offices physically to ask a question. We also have the CEO and other people on the executive leadership team who shake hands with these people. That personalization means a lot. Look, I'll just say it. This is the most entitled generation in America, seniors. It's not millennials. It's not millennials, let me be clear. It's seniors. They've earned it. And I say that as a compliment. I've lived this long. I've dealt with a couple of wars. I maybe even fought in one war at least. Many economic downturns, all these things. Get off my lawn and give me my health care. And by the way, they've earned it. That's a compliment. And so I think we have to take that mindset into any interaction we have, whether at the street level layer or the macro layer with marketing strategies. These people have earned this coverage. Make it as easy as possible for them. Look, I've worked in insurance for a very long time. When I took this role in August of 22, I had to call our employment insurance group and ask them a couple of questions. Imagine being 73 years old and never working in insurance. This is hard. So it's incumbent upon us to use the federal dollars to make this as easy as possible for these folks, for that reason and many more.
Where do you see your industry, the Medicare Advantage plans going, like as a role to sort of be part of healthcare transformation?
Yeah, it's a really good question. I would argue that's the most important question for the long-term viability of our industry. The honest answer is I don't know. But beyond that, what I hope will happen and what I think will happen is there will be a calibration of benefits the industry is offering versus what consumers want. And then we can come to a meeting of the minds in terms of having these folks sign up for these plans, which means keeping them attractive, while at the same time holding our industry accountable for total cost of care and all the things we need to do to take care of these people. That has been, in my mind, the premise of this entire industry since 2003, when the Medicare Modernization Act was passed. But I think there should be a sit down between industry leaders as well as CMS leaders to really understand what these folks want, because we're boots on the ground. I think we could inform them much better than we are today about what these folks want, which would have a much better answer to your question, Michael.
Yeah. So how do you, it seems, with healthcare is complicated, it's complex. With a plan is only as good as the providers and all the different, I guess care providers. How do you make sure that you keep a check of that to really make, how do you do that? It's so complicated with all the different parts of your network. What do you do as you are overseeing that to get that kind of feedback loop and innovation to continue to improve your offering?
Yeah, so really good question. I've always looked at health coverage as a three-legged stool. It's benefits, it's network, it's brand equity. Because if your benefits and your network are subpar or average, maybe your brand could carry you through because they trust you. That being said, when it comes to provider partnerships, and I emphasize the word partnership, I focus on what John Lennon said, which is I get by with help with my friends, or from my friends, sorry. That being said, I believe in true provider partnerships. I don't go to a provider, irrespective of what they do or how they do it, and impose my will upon them. I ask them what they need, and I try to meet them in the middle with what we need. I find when you take that approach, it typically works pretty well. You create a true partnership with people. The concept of downside risk or risk in general, depending on who our industry you talk to, you can have 10 different definitions from 10 different people. I like to focus on a provider partner taking risk when we both agree that they're ready to do so. Because if they're not ready, then it's reckless of me to push them down that road. Okay. So beyond that, I always focus on providers who have the heart of a teacher, and they don't look at an interaction at the point of care as transactional. Don't look to go to the next patient, focus on this patient. Okay. That's kind of the model I like to work with the best. Beyond that, we work with other providers because without them, we can't serve our members. And we work with them very intensely with the provider engagement team, which is an all-star team. And we recognize they are our customers. The member is our customer, but there's an intermediary there that's called the provider. So we focus as equally as much on the provider being our customer as we do the member being our customer.
Yeah, I think those are some pretty interesting insights when you start thinking about risk and providers, but also their bandwidth is limited because providers are accustomed to seeing so many patients in such a small, limited window of time. And for them to be able to spend all that time and energy in building these relationships with patients is problematic as cost containment continues to be challenged. So are there unique ways to touch patients in the comfort of their home when they want access to care without having to utilize the transportation, the scheduling, and other elements where you can touch them in a similar fashion, but at a fraction of the cost, and also potentially increase, your patient satisfaction, just given that the limited resources and burden that exists within the labor market? Are you trying to do things different or innovative that are unique versus just trying to maintain the same provider relationship with your patients? Or is that really where the reimbursement stands right now? And it's challenging to kind of move to that next hurdle.
Yeah, that's a good point. The answer is yes. We are going into the home. We are going into the home in a variety of ways. I'm not a clinician, but I know enough about this world because I'm obsessed with doing good at this job in this industry to know that I don't know why house calls ever had to stop. Why did they have to stop? Why not? Because you can probably take care of the most vulnerable of the population if you simply make house calls. So yes, we are in partnership and in talks with other entities who can help us with that. That personalization matters. Look, healthcare, especially in Medicare, it's a 90-10 rule. Generally speaking, from a financial point of view only, it's my belief that generally if you take care of the 10% that are the highest acuity, you can solve 90% of any business problems you have. And obviously that doesn't mean we ignore anybody. It just simply means that you focus your prioritization on certain cohorts of membership, because underwriting does not exist in Medicare Advantage. That's one interesting nuance. Auto insurance, home insurance, other health insurance, life insurance, underwriting exists. In Medicare Advantage, it does not. In group Medicare Advantage, it does. We are individual Medicare Advantage only. And so we have to, in a very scientific way, try to diagnose any certain risk we get because of that.
When you talk about, I love how you said that house calls should have never stopped. I love that. But, I also think the smartphone text, it seems like there's so many things that you can do before that too. Or have you guys adopted or worked with the providers to use, and I don't want to use telehealth because I think that's been misunderstood, but it just seems like just texting and different ways to engage or help facilitate that for the members. I don't know if you have any demonstrations or any programs that you found very effective to improve, to lower the cost of care and to improve that satisfaction.
Yeah, we have. I've used that a couple of times, and it works. I think it works for depending on the demographics that you're associated with. For instance, There are certain demographics in our world, and specifically with the Medicare Advantage, where that would be ineffective, like it would be nil. There are other demographics where it would work. So on a case-by-case basis, the answer is yes. Beyond that, are we proactive as we can be while at the same time being compliant to reach out to people through a variety of means? Absolutely. Just like there's never a downside to knowing too many people in your professional network, there's never a downside to at least offering a member some help if they should need it. The only downside is if you're obnoxious about it. You know, if you're sending 17 text messages and 34 emails a day, maybe pump the brakes. So there's that fine balance between what people want and versus what you're pushing on them. But yes, we absolutely employ those things.
And it's two-way, not just one way.
Meaning,
I mean, like a member can get some help or something through not just updating them with their colonoscopy or whatever. Like there's like ways to have back and forth exchange.
yes, through the provider mostly, through various means that we all know of through the provider. Yeah, but otherwise, look, we are broker only. Okay, we don't have any salespeople, quote unquote, at ATRIO. That's done on purpose, and the reason is because in an ideal world, I want all the brokers to start from the zero yard mark and go race for the business, because I think creating that meritocracy under the cloud of compliance does best for the member, frankly. Beyond that, outside of AAP, we ask the brokers to keep in contact with their members they signed up so that we can solve these sorts of things. Like, gosh, I'm playing make-believe here, but I wish I could really talk to the insurance company without calling them. Okay, let's find out a way to do that. And so we rely upon the brokers to do that, to give us that feedback. Being a rural health plan, that sort of activity is not as high as what I'm used to. I've mostly worked in urban health plans in the past. Folks in the rural community apparently are not as engaged in that sort of activity. But we do all we can through $0 PCP copays, to broker engagement, to having customer service in Oregon, Salem, Oregon, which seniors like. It's not 14 million miles away. We do all these things to try to address their concerns and answer their questions. That's a longer answer than you wanted, but
no, it was very helpful, because it's a little more, you unpacked it, and it seems like you're really trying to reach the members. It's a complicated answer. I think it was helpful that you shared with Salem, Oregon. You're trying to have them know that they're being provided by people that are local and part of the community. I think that's a big importance. Do you tell me what, like, you have a huge burden as a CEO. What keeps you up at night? And I mean, just, I can only imagine, the amount of lives that are dependent on you, from as your team, your employees, but the members.
yeah. So thank you. I'm going to respectfully correct you, though. It's not me, it's we. It is, forget about my title. I don't run the show. I collaborate with others and I make the final decision. But I rely upon a team of very capable, dedicated folks who are competent in their field to take care of these people. What keeps me up at night, beyond a snoring English bulldog, is what comes around the corner. And by that, what I mean is, so in this industry, I've been asked a few times, like, what is your 3-year plan, your 5-year plan? I would argue in Medicare Advantage, any 3 to 5 year business plan you put out there is a best guess on the best day. because CMS could change things tomorrow. They could change things next year in the rate notice to make us alter that plan. That doesn't mean we don't plan for the future, but that's the thing that keeps me up the most, which is there's a large degree of unpredictability about our industry that makes me stay on my toes, which is a good thing, and makes me think chess rather than checkers when it comes to taking care of these seniors.
And Charles, go ahead.
Yeah, I was going to say that's pretty interesting, because if you really start to see how CMS is moving forward in the future, it looks like they want to reach seniors at a lower cost point. They want to treat people in the home without having to really change the way that they are living and improve the quality of care. And then some of the star ratings that are actually being reflected but are being pushed out in the marketplace are really focused around that patient in the home. So when you start looking at that 3 to 5 year plan, if you know that utilization needs to be reduced, if you know total cost of care needs to potentially come down, and we know we need to serve people in the comfort of their home and reduce the amount of hospitalizations, readmissions, or ER visits, is there different strategies that you can think of that are different than what's currently happening right now, where we're essentially pushing patients directly to the clinic or to the hospital? And you mentioned a little bit about, some of the partnerships that you had servicing people in the home, but do you see any drastic innovations of technology that could potentially swing the pendulum to service like we used to, where the patient is being seen at the home and developing and being independent at home, self-servicing themselves, versus right now being dependent on caregivers and providers?
Yeah, I think it's a really good point. If everything were out of the way, then in an ideal world, we would rely upon loved ones and family members and friends to get through to that person. So, case in point, if somebody that none of us knows calls us right now and says, I've got this awesome thing that you should be interested in, let's make up something. You love golf, okay? I've got this awesome new club that is like going to make your golf game so much better, blah, 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 blah. If you don't know that person, imagine that conversation versus your sibling, versus your cousin, versus your mom or dad saying, hey, Charles, I heard about this new club. Like, one of those conversations you're going to take much more seriously than the other, right? And so I think, look, there are many companies out there that do companionship and in the home, clinical and non-clinical. We're all familiar with them. I think the genie in the bottle is figuring out a way to get the family and the loved ones bought in to that in-home care. Because it's one thing to convince the senior who gets phone calls all the time, unfortunately from bad actors sometimes. That's much different than having a family member call in and say, you should take this call.
Yeah. And it's something that we've actually done, and you've just spelled it out for everybody that's listening to the podcast, is the most effective thing that we have with our AI robotics technology is actually messaging the loved one when something deviates in the behavior, so they can check in with that family member. And that is a drastic impact in behavior modification. So I think you're absolutely spot on with that. Once you get the caregivers and the family members involved, because they have that strong bond and relationship, you can alter, someone's chronic disease state, or you can alter the trajectory of them potentially utilizing a high resource. So I think you're spot on with that.
Well, it's just like word of mouth, how we, someone tells us something and it's, we're influenced by our friends and people around us. It seems, rather than, I hate this, not necessarily by a health plan, right? Unfortunately, that's a big barrier. Is that kind of what you're getting at, Gregg? I
think so, but I won't displace what you said. I will add to it. I don't think it's word of mouth. I think it's word of mouth with credibility.
Yeah.
So if I eat at McDonald's 3 times a day, you should not take my opinion seriously if I say that this is the best steakhouse down the road, right?
Yeah.
But if I really love steak and I understand the minutia of how steak is created, you should probably take my word with some credibility. So I think that may be the bifurcation between those 2 points, in that you're right. It's word of mouth, but it's word of mouth with credibility from someone who's like, I love you, and this is the reason I'm telling you, you need to take this phone call.
Well, Greg,
I think that's the big thing to overcome.
I really appreciate you coming on today. I want to be respectful of our time. We're at the hour, and this has been great. Is there anything you want to just put out there, share? You've been so helpful to kind of let everyone know more about what you're doing and how you're serving our seniors.
Yeah, I get pretty verbose, and I know I've talked too much already, so I don't have a lot else to add. This has been super fun.
Yeah. Well, thank you for coming on.
Thank you, guys. Talk to you soon.
Yeah, take care.
Until next time.